we don't complications. Because, I still remember, these pharmacy students used to come to us.
Okay, sir.
So they used to be posted for 1 month, these pharmacy students, and they used to study the drugs and their complications along with us. So for every time, they used to say bupivacaine will produce severe hypotension, propofol produces severe hypotension. Like that, they were considering that as a severe side effect of these drugs. And they were even reporting that. So then, actually before reporting, actually they came and asked me, shall we report these side effects, severe side effects of these drugs? I said there is no question of reporting because they are effects of these drugs which we do not want, so they are called as side effects. So there is no point in reporting, and we are regularly we observe these effects of these drugs, and we manage. So that's how their routine things. We don't consider that as a complication unless it is a very severe hypotension that is produced intraoperatively. Otherwise, it's routine. So any such unusual complications you came across?
No, sir.
No, nothing.
Nothing, sir.
That means very boring week.
Yes.
So we have started using intrathecal morphine for LSES.
Oh, very good. What a change. Very nice. At
They are
least,
doing thesis.
no,
Intrathecal morphine.
just started, is it?
Yes.
Yes, sir.
So one of the newer postgraduates must have been given this topic
Yes, sir.
for dissertation.
Yes, sir.
Yes,
Yes, sir.
Intrathecal morphine. How much? 100 micrograms?
100 mics, sir.
100 mics. But it is a old one. What is new in that? It is not a newer,
We have started.
In our institute,
our
we have
institution,
started,
we
sir.
started.
In your institution, it has not been done probably. So in your university, it is a new thing. But no, if you want to publish, whenever you do your dissertation work, it is always, you should always be thinking in terms about publication. So that is what. And if you want to publish, it should be a newer thing, isn't it? Or you can compare it with others, like comparison between intrathecal buprenorphine, intrathecal morphine, a comparison between the two drugs. So their onset of spinal effects and also mainly post-op analgesia, because both drugs are used mainly for post-op analgesia, because the onset of action of these drugs is quite late, even though you have given that intrathecally. Especially morphine, I told you it will take about 60 minutes to start acting. And epidurally, it may take even 90 minutes to 2 hours to start acting, because it has to cross the dura, and then it has to enter the CSF and start acting in the spinal cord. So that's how onset of action is delayed. So did you ask, they have already used or not used? Started using or not used?
They have already started, just started using, sir.
So did you go and then inquire about the post-op analgesia?
No, sir, for 24 hours, patient having no pain, sir.
Absolutely very comfortable, isn't it?
Yes, sir.
So that is a single dose that produces quite a bit of prolonged post-op analgesia. So that is what in Western countries, it is a routine. They, for all patients, cesarean section, they don't give only intrathecal bupivacaine. They always add morphine. Morphine is the gold standard for intrathecal post-op analgesia. And I told you, morphine also has been used now in pediatric cardiothoracic surgeries. And they just give single dose of morphine intrathecally, and it produces post-op analgesia, very effective post-op analgesia. And they're not bothered about post-op respiratory depression, because anyway, they are going to ventilate. So another area where we need to give morphine is scoliosis surgery. I was told by you that you are not doing many scoliosis. But again, in scoliosis surgery, two problems are always there, or actually three problems in scoliosis surgery. One problem is intraoperative bleeding, massive bleeding that you have to look after. The second thing is, so when they apply the traction for the vertebral column. So you have to monitor. There are two things. One is either wake-up test or you go for the motor evoked potentials and sensory evoked potentials. So neuromonitoring that we discussed actually. So that way, when you are doing that, so wake-up test nowadays, we hardly do it because now availability of neuromonitoring intraoperatively is always there. You can continuously monitor the evoked potentials. So the advantage of opioids is that they do not, already we discussed, they do not have any effect on the latency or on the amplitude of the evoked potentials. So that way, when you are using the opioids during intra-operative use, and of course, along with propofol you have to use. You cannot use muscle relaxant. So that is one thing because if you're using motor evoked potentials and if you're using muscle relaxants, then it will totally block muscle relaxants, isn't it? So you cannot. So if you're using atracurium, so at least the last dose of atracurium should be about half an hour or 45 minutes before you start checking. So that is very important. Or reverse in intraoperatively, you may have to even reverse the effect of atracurium using or cisatracurium using neostigmine and glycopyrrolate. And then when they are using actually the neuromonitoring. So in such situations, ideal would be to continuously use remifentanil infusion at the rate of say 0.05 microgram per kg per minute to 0.1 microgram per kg per minute operatively if you are using. And second thing is you cannot use inhalation anesthetic agents because again inhalation anesthetic agents will both depress the amplitude and also prolong the latency of evoked potential. So you have to go for only, you cannot even use, many times they say that nitrous oxide is okay, but we don't use nitrous oxide also. We'll be managing the patient with oxygen and air, ventilating with total intravenous anesthesia. Along with, remifentanil is the best drug. If you are not having remifentanil, you can use fentanyl as well. So that both drugs will not have any effect on evoked potential. So for post-op analgesia, because another third problem in these patients, other than you will have to do a neuromonitoring and intraoperative blood loss, is third problem is the severe pain in the post-operative period. You want to early ambulate the patient, but the patient will have very severe because the incision would be a very long incision on the back for correction of scoliosis. So in such situations, intrathecal morphine, a single dose of say 100 to 150 micrograms for these patients definitely will help. But one more thing you'll have to keep it in your mind is some of these patients, especially because of scoliosis, kyphoscoliosis especially, they'll have restrictive lung disease. And that you will have to study their lung function tests before. And some of these patients, very rarely, they can even develop right ventricular failure as a result of severe hypoxemia, hypercarbia, and pulmonary hypertension, ventricular hypertrophy failure. So right heart failure may be there, but in such patients, you have to be extremely careful in using drugs because further respiratory depression you should not produce. But continuous monitoring, anyway, you'll be monitoring these patients in the post-anesthesia care unit for at least about 24 hours. And that way it will help. So you can even make them ambulate very early. So that way, the opiates, definitely intrathecal opiates like morphine is going to help. So another thing also, you can use patches of buprenorphine or fentanyl patches for these patients much earlier. Already we discussed about transdermal fentanyl when we were discussing about individual drugs. So transdermal fentanyl, definitely you can apply 12 hours before the surgery. And post-op, it will be producing very effective analgesia for say 48 to 72 hours. So other than fentanyl, you can also use buprenorphine patches. We'll be discussing today buprenorphine because individual drugs we are discussing. Mostly we will have to discuss buprenorphine, pethidine, then tramadol, tapentadol, then kappa receptor agonists like pentazocine, butorphanol. Those things also we'll discuss. So anyway, good thing that you have started with intrathecal morphine. You can also try, not for cesarean section, even for other, major surgeries, especially the abdominal surgeries like Whipple's. Actually, about 3 days back, one of my students, now who is a professor in one of the medical colleges in Karnataka, she was asking what to give for Whipple surgery. She was supposed to have undertaken the Whipple surgery anesthesia. I told her, you give intrathecal morphine, so patient will be very comfortable in the post-op period. And she rang me up yesterday and told me that patient is absolutely fine, though he's kept in ICU, but he is very comfortable as far as his pain is concerned. Because Whipple surgery, again, major surgery,
Yes.
prolongation of surgery, and plus the incision is quite big as far as the abdomen, from almost the sternum to below the umbilicus, the incision would be there. And there you require a very good post-op analgesia also for these patients, malignancy patients. Of course, you'll have to think about suppression of immunity and, recurrence of malignancy after opiates, but it has not been very definitely proved regarding the recurrence of malignancy when you use opiates, during intraoperative period and also for post-operative period. So many of the studies have not found any effect as far as recurrence of malignancy, because I was discussing with these, they had, studied in colon surgeries, colon malignancies and prostate malignancies. And some of the studies had found that there was recurrence when you use intraoperative and postoperative periods, but it has not been proved at all. Especially, I was discussing with some of the HOD and other professors from cancer hospital in Trivandrum. So there is a separate independent cancer hospital, and they are now using intrathecal morphine for abdominal malignancies for post-op analgesia. So they have given a study for one of the students there for how long post-op analgesia will be there. So they were telling me that especially since it's a cancer hospital and they are using, and they have studied extensively regarding many of the studies and not found that opiates may have immune suppression and may have an increased incidence of recurrence of malignancy. So that is now ruled out. So definitely you can use. So that is about the intrathecal thing, because
Yeah.
you also have started using. It's a nice thing. So did you actually inquire with your teachers about intrathecal morphine use? No, I told you to go and then ask your professors why we can also try in our hospital. Like, you had not
Yeah.
talked to or spoken to your teachers regarding use of intrathecal morphine. Pardon?
Yes. In the epidural, we are giving morphine.
No, epidural, okay. Intrathecal, I was telling you.
Intrathecal.
I had told you just,
Yes, sir. Yes,
for
sir.
you, because, you'll be taking exam in another 3-4 months and you'll come out and then you'll be consultant. So you should have good experience about many things, isn't it? So that, you can also start using in your, as a consultant when you become later. So that is there. And another thing is, we were discussing about individual drugs,
Yes,
opioids.
sir.
So we had completed codeine, we had completed
Codeine.
morphine, we completed fentanyl.
Yes,
And we also completed remifentanil. I don't know.
Remifentanil, sir. We completed. Sir.
So we had completed.
Completed, sir.
And any doubts regarding these individual opioids? Because I usually ask about any doubts if you have. And any doubts regarding anesthesia itself, I was telling you, so that, we can briefly discuss for a few minutes, and then actually we can go into our regular discussion. Any doubts you had regarding these drugs, especially remifentanil, because you are not using remifentanil.
Yes, sir.
You can always request your teachers also to get remifentanil and start using it in your institution. A fantastic drug, I told you, because it's rapid onset, rapid
Rapid
offset.
onset, rapid onset.
Rapid offset acts in 1 minute
Automatic.
when you give intravenously,
Yes, sir.
and the duration of action is just 4 to 6 minutes,
6
single dose. So you have to use it as an infusion only. And context sensitive half time does not change with the duration of infusion. Whatever may be the duration of infusion, even 20 hours you use, you stop the drug, after 3.5 minutes, the 50% reduction in the plasma
Mm.
concentration will occur. So that is the beauty of remifentanil. So that's how you have a total control on the patient's pain when you're using remifentanil. And when you do not want to use it, you can stop it. But
Yes.
one thing is remifentanil also has got all the side effects of opioids. Like
Yes.
any opioid, it also can produce all the other, like respiratory depression. It can produce constipation when prolonged use. It can produce nausea, vomiting. It can produce retention of urine and also pruritus. So all these, which are the most common side effects of opiates, remifentanil also can have. And I told you last, I think, class, remifentanil nowadays is also one of the drugs of choice when you
Labor analgesic.
labor analgesia, when the mother do not want or does not want any central uraxial analgesia. So remifentanil is used, but when you use remifentanil, again the mother has to be monitored very well. There are 6 cases of case reports where mothers have gone for respiratory depression and even respiratory arrest has occurred when they were using IV remifentanil at a low dose. So 0.05, 0.025 to 0.05 micrograms per kg per minute is the dose. And also it is always used with a patient controlled IV analgesia pump. So the lockout period, so individual bolus will be roughly about 0.5 microgram per kg body weight bolus, and lockout interval is 2 minutes. So every 2 minutes, if she presses the button, she can have a 0.5 micrograms per kg body weight of the drug. So that is there, but there are some case reports of respiratory arrest with remifentanil. So though it's a very good drug, but the side effects are also there, and then you have to monitor the patient. So those things are very important. Okay, now coming to the other drug, which is very commonly used in most of the places, and you also said you are extensively using, is buprenorphine, isn't it? So buprenorphine invariably will be kept for you for the exam, and the ampule of buprenorphine will be given to you. So, okay, Aarti, if you are given an ampule of buprenorphine, how do you start?
It is a 1 ml drug.
No, it's usually it comes as 1 ml or 2 ml. Both the 1 ml, 2 ml ampules,
1 ml.
both are available. 2 ml, 600 micrograms, 300 micrograms. So you can always say, okay, it's an ampule containing buprenorphine. Contains in each ml how much?
1 ml, 0.3 mg, sir.
300 micrograms. So you can always say 300 micrograms per ml. Okay, what type of opioid is it? As far as classification,
It's an agonist antagonist.
yeah, it is an agonist antagonist. Where it is an agonist? Which receptors it's an agonist?
Mu receptor.
Yeah, mu receptors it's an agonist. Is it a complete agonist or a partial agonist? No, that is the most important thing you'll have to talk about, isn't it? So you should have started with like it's a partial agonist at mu receptors. It's a partial agonist at mu receptors, and it's an antagonist at kappa and delta receptors. That is the thing which we call it as agonist antagonist. And as far as its manufacture or structure What kind of drug is it when you classify? Like morphine
Depend,
classify
depend.
as, yeah.
Depend.
No, morphine you classify it as naturally
Oh,
occurring.
morphine natural. Yes, yes.
Buprenorphine, fentanyl is synthetic.
Synthetic.
yes.
Morphine is naturally occurring alkaloid. Fentanyl is synthetic. Buprenorphine, we have discussed the classifications and all before only. Semi-synthetic. That is what you should start with. When you are given the ampule of buprenorphine, you can always tell it is 1 ml of buprenorphine containing 1 ml ampule. It contains 300 micrograms per ml. It's a semi-synthetic opioid. It's a semi-synthetic opioid, and it is a partial agonist at mu receptors and antagonist at kappa and delta receptor. So it is classified as agonist antagonist. So what do you mean by partial agonist? Like morphine, fentanyl, pethidinol, they are complete agonists.
Yes.
Whereas buprenorphine is a partial agonist. So what do you mean by partial agonist means what? What about its affinity to the receptors? Percentage of affinity to receptors?
50%.
No, affinity to the receptors is 100%. What about its intrinsic action after combining with the receptor? What about the intrinsic activity it produces? It is 100%, 50%. What about the intrinsic activity? It is 50%.
50%.
What is, the difference between an agonist and a partial agonist and an antagonist? So these things you should always remember about. Already we had discussed, but just for revision, I'm telling you. An agonist is the one where the affinity to the receptors is 100%. Intrinsic activity is 100%. That is a complete agonist. A partial agonist is the one where the affinity to the receptors is 100%, whereas its intrinsic is only 50%. That is why it is called as a partial agonist. Okay. When do you call it as an antagonist? Is its affinity to the receptors is 100%. Affinity to the receptors is 100%. But after associating with the receptors, it produces a zero intrinsic activity. That is an antagonist.
Okay.
So it won't produce any intrinsic activity. It produces a zero intrinsic activity. That is an antagonist. So buprenorphine has got a complete association with the mu and delta and kappa receptors. 100% association, 100% affinity. But its intrinsic activity at the mu receptors is only 50%. That is why it's called as a partial agonist. And again, its intrinsic activity at the kappa and delta receptors is 0%. That is why it is called as an antagonist at kappa and delta receptor. So that is the reason it's called as a agonist antagonist drug. It comes under agonist antagonist. So that is one advantage. So how many times it is more potent than morphine? Because morphine is considered as the gold standard as far as analgesia is concerned, as far as opiates are concerned, and we always compare other opiates with morphine. Like fentanyl is 100 times more potent than morphine.
30 times.
Morphine, yes, it is about 33 times as potent as morphine. Okay, so other than the opiate agonistic antagonistic activity, what other activity also buprenorphine has? Already last time I had discussed about this when I discussed about opiate-induced hyperalgesia. What other effect buprenorphine also has? Wherein it can be used for opiate-induced hyperalgesia, it can decrease this particular opiate-induced hyperalgesia when you use buprenorphine at the dose of 25 micrograms per hour. Very low dose buprenorphine when you give just 25 micrograms per hour. So you don't have opiate-induced hyperalgesia. And also I told you what is the mechanism of opiate-induced hyperalgesia.
NMDA receptor.
NMDA
NMDA receptor activation,
Activations.
isn't it? So that's why, if any drug with NMDA receptor antagonistic property can be used for opioid-induced hyperalgesia, like you had said about
Ketamine migration.
Ketamine, yes,
or like that, buprenorphine also has NMDA receptor antagonistic activity. That is the advantage of buprenorphine. If you think that yes, the patient requires continuous opioids, and there is always a possibility of patient developing opioid-induced hyperalgesia in the postoperative period, so you can give buprenorphine at a very low dose, 25 micrograms per hour. It is not per kg per hour. It is just 25 micrograms per hour. For example, if you have got a 300 microgram ampule, so you can give for 15 hours or say 12 hours, isn't it? It's roughly 12 hours, 300 micrograms come for 12 hours. So you can use 2 ampules in 24 hours infusions, so that it is going to prevent opioid-induced hyperalgesia, and opiates will be very effective. So that is an advantage with buprenorphine. What other important activity it also has other than the NMDA receptor antagonistic activity? So that it is very effective when you are using it in the epidural route, intrathecal route, along with local anesthetics in any other regional blocks, field blocks. What other important property it has?
Intrathecal, we can use buprenorphine.
No. You are using intrathecally also. You can even use for brachial block, for sciatic plexus block, sciatic nerve block, sacral plexus. Any of these, infiltrative anesthesia also you can use along with local anesthetics, because it has got a local anesthetic effect as well. So that is what you have to know. It potentiates the action of local anesthetics. Potentiates the action of local anesthetics, but plus it takes care of second pain. Already I told you what is first pain, second pain, isn't it? Local anesthetics take care of first pain.
First pain.
First pain is because of the pain transmitted through
delta
delta fibers, and second pain is
C fibers.
C fibers.
because it is an opioid, it also blocks the pain transmitted through C fibers, and also because it has got a local anesthetic effect by itself, it also potentiates the effect of other local anesthetics, so that effective blockade of the pain transmitted through A delta fibers. So that is an advantage with buprenorphine. Okay. So the other important method of administration of buprenorphine is it can be used sublingually. Sublingual tablets are available. Buprenorphine tablets are available. So you can use 0.2 milligrams and 0.4 milligram tablets are available. So the onset of action will be within say 1 hour onset of action, and it is quite effective. It bypasses the first pass metabolism. So that way it can be used for acute pain, and especially this is being used in cancer pain. Buprenorphine. And also buprenorphine can be used through transdermal route. Transdermal patches are also available. Transdermal patches are available. So you have 5 microgram, 7.5, 10, 15, 20, 25, or up to 20 micrograms per hour patches are available. So if you want to use a patch for post-op analgesia, so when you have to apply, how much before? Like fentanyl, I told you 12 hours before you have to apply fentanyl patch. Buprenorphine patch, when you have to apply before the surgery to produce post-op analgesia.
Around 8 hours before surgery.
You are guessing. So it is 48 hours before you may have to apply. At least 2 days before, because the onset of action may take nearly 36 to 48 hours. Prolonged onset of time. But how long the effect of post-op analgesia will be there once you use it? Up to 7 days.
7 days.
Whereas fentanyl will be there for 72 hours, for 3 days. Whereas buprenorphine once it starts acting, so it can continue to produce analgesia for up to 72 hours, this is for up to 7 days. That is why buprenorphine is many times it is used for these surgeries, especially where prolonged pain will be there, like knee replacement, TKR, total hip replacements. So it can be applied at least 48 hours before, and the patient can have very good analgesia for 7 days post-operatively. And intrathecally, you can also use morphine also. So that is going to produce analgesia for 24 hours. So that way, effective analgesia you can use, provided you know when to use each drug, how to use. That is what is very important, isn't it? So all drugs are very useful, provided you know how you should use. For knowing how to use, you should know in depth about pharmacokinetics, pharmacodynamics of these, isn't it? So you can be safe, or any drugs can be safe in safer hands. Safer hands means knowledgeable persons, isn't it? So very important about knowing about buprenorphine patch. It is available. It is available in your pharmacy also. So definitely, buprogesic patches are available. So you can use for post-op analgesia as well, or many times it can be used. Majority of the times it is used by onco surgeons, or even chronic pain management, especially the cancer pain management people. So they'll be using this. Okay, so another important thing about buprenorphine is it also can produce all the side effects of opiates, except it won't produce much of the pruritus. But I told you that one patient had extensive pruritus, and especially the scalp. So she was posted for hysterectomy, I think I told you. So I had to convert to GA intraoperatively, and then afterwards I found a lot of lice in her hair. So that has probably exacerbated the pruritus produced by the lice by buprenorphine. So, but usually it may not produce so much. But another important thing is the log dose response curve of buprenorphine. So what is the shape of the log dose response curve of buprenorphine? Because it is a semi or a partial agonist. It is not a complete agonist.
Bell-shaped.
Bell-shaped. It is a bell-shaped log dose response curve. That means after a particular maximum dose, the analgesia will not increase. Actually, the analgesia may start decreasing. Analgesia may start decreasing. That is why it's called as the log dose response curve is a bell-shaped one. It has got a ceiling effect. Ceiling effect. Usually, the ceiling occurs after about 600 micrograms of buprenorphine. Once you use more than 600 micrograms of buprenorphine, many times the ceiling will be there. Not further increase of dose may not increase more of analgesia. That is always there. And it has been found that it may not produce so much of respiratory depression. And there is a ceiling effect for respiratory depression also. So that is also there. But one problem with respiratory depression produced by buprenorphine is, it is, you will not be able to reverse with naloxone easily. Because you know that majority of the respiratory depressions produced as a result of the opioids can be reversed by naloxone. So, but except buprenorphine. Why buprenorphine respiratory depression may be resistant to naloxone? Now, these are important things you will have to tell in the exam. Important property of buprenorphine other than other opioids. Like the respiratory depression is not common, but if it occurs, so it may not respond to naloxone. Why?
Partial agonist and antagonist.
No. Nothing to do with that. Partial agonist or antagonist. Because one thing is it won't dissociate from the receptors easily. Once it associates with the receptors, it won't dissociate very easily. Like all other opiates like morphine, fentanyl, alfentanyl, so whatever it may be, they associate and then after a few probably seconds or minutes, they'll dissociate. Whereas buprenorphine associates with the receptor for a long time. So since it associates with the receptor for a long time, naloxone cannot displace it. What happens is naloxone is a competitive antagonist. So once, the opiates get displaced from the receptors, it will go and occupy. So that opiates cannot go and reoccupy. That's how, the respiratory depression gets antagonized by naloxone. Whereas because buprenorphine has got a long association with the receptors, so the naloxone may not be able to displace buprenorphine. So how do you manage? You can still use naloxone, but you should always remember that it may not produce effective reversal of respiratory depression. So if such a thing occurs, unfortunately, because you say that you are using buprenorphine intrathecally, it also can produce. But what is the difference between the respiratory depression by buprenorphine and morphine? When morphine produces respiratory depression?
6 to 8 hours.
Yeah, later, 68
Later,
hours.
68
What
hours.
about buprenorphine? When it can produce? Produces within 2 hours.
2 hours. Okay.
Because it's a highly lipophilic drug. Unlike morphine is more hydrophilic, buprenorphine is highly lipophilic. So it gets into the circulation and it will be effective on the supraspinal mu receptor that is in the brain. That is why it can produce respiratory depression within 2 hours, if at all, if it produces. So even when you give IV buprenorphine also, it can, or IM buprenorphine you can use, IV buprenorphine you can use. So sublingual, transdermal, I told you, these are the different routes of use of buprenorphine. So it is called as a psychotropic drug, and in India, you may not require any narcotic license for buprenorphine and tramadol.
Yes, sir.
That is how it is available in your medical stores. You can prescribe and then you can get it from your medical stores for use for anesthesia. Unlike fentanyl or penicillin, morphine, and all those things, they do require separate narcotic license. So that is an advantage of having buprenorphine, so that quite effective intrathecal analgesia and also other routes are there. So because of its long association, so it may produce prolonged respiratory depression and may not be reversed with naloxone. So how do you manage respiratory depression by buprenorphine? So another thing I told you, yes, okay, difference between morphine and this thing I told you, and how do you manage?
100%.
100% oxygen. Say we will intubate the patient, ventilates.
Yeah, you have to ventilate.
Intubate the patient, ventilate.
The best thing is, to ventilate the patient till the patient comes out of respiratory depression. And that is one thing you should always remember about when you want to use buprenorphine. So what is the dose of buprenorphine you can use for intrathecal, for epidural, for intramuscular, intravenous? Transdermal, I told you, you can go for 5 and all those. So intrathecal, what is the maximum dose you can use?
30 to 90 mics.
You can go up to 150 micrograms. 150 micrograms buprenorphine has been used, and you can definitely go up to 150 micrograms. We used to regularly use 150. So half ml of buprenorphine regularly using. I've never had my experience, but I've never had any respiratory depression because of buprenorphine. But one of my friends had told that he had one case of respiratory depression when 150 micrograms of buprenorphine was used intrathecally. So since you are using 60 micrograms, that is quite safe, and the quite advantageous as well. So 60 micrograms is quite safe. Okay. What about IV buprenorphine? How much you can use? What is the dose?
0.1,
Point,
0.1,
point one,
0.1 mg.
0.1 mg, so much, 100 micrograms per kg body weight, is it?
0.0.
It is all 3 micrograms per kg body weight. 3 mics. So all other routes other than intrathecal you can go from 1 to 3 micrograms per kg body weight. Epidural it is 3 microgram per kg body weight. And intravenous it is 3 micrograms per kg body weight. Intramuscular also it is 3 micrograms per kg body weight. So you can definitely use 3 up to 3 micrograms per kg body weight. So for intraoperative analgesia as well. So, but the main problem again is it's a prolonged duration of action is there. So that is the reason why we don't usually use it for as a pre-medicant drug. So because we have shorter acting drug opiates are there, like fentanyl is there. So we are routinely using fentanyl for as a pre-medicant and also as an intraoperative opioid, isn't it? So buprenorphine can be used for post-op analgesia. IV buprenorphine can be used at least about same again, its onset of action is quite delayed, like morphine. So peak effect even after intravenous may take about say nearly 2 hours for its peak effect. So it may have to be given much earlier. Like morphine has to be given at least 1 hour before. Like buprenorphine also may have to be given at least 1 hour before. Okay, so these are the things which you have to tell about when you are given a buprenorphine ampule. Okay, so invariably because it will be there, because it is one of the most commonly used drugs, as you said. So in your institution, so that is the reason it may be regularly being used. Okay, so any questions on buprenorphine? Any doubts you have regarding buprenorphine? Again, all side effects like nausea, vomiting, all those things there with buprenorphine. So that you have to take care. Urinary retention, then constipation, paralytic ileus, everything, or like any opioids, it can also produce. Okay, so if you don't have any doubts, anybody else has got any doubts regarding buprenorphine, because you people are using buprenorphine routinely in your institution? Because we can move on to the other drug. So another drug which can be kept for you in the exam and it may be available in your institution also is pethidine. Is pethidine available in your institution?
It was available before, sir. Now we are not having any stock.
Many times pethidine is routinely used for shivering, post-op shivering.
Post-op shivering.
In JSS hospital where I was working, and even in Mysore Medical College, we used to use for post-op shivering, that is the gold standard drug.
Yes, sir.
So invariably, it will be there in the institution. And in olden days, we used to use routinely pethidine because we did not have fentanyl and morphine was not available during those days. Pethidine was routinely available. So as a pre-medicant drug, intraoperative use, pethidine was the most commonly used drug. That's what I told you in one of the cases with severe hypothyroidism. I had just given 25 milligrams of pethidine. Patient had gone for respiratory arrest because severe hypothyroidism was there, which was not detected till then. So that's how, pethidine was routinely used. Nowadays, we don't use pethidine much. So pethidine is available in 2 ml ampule. So you may be given one ampule of pethidine for the exam. So how do you start? Okay, Gaurav, you can tell me, how do you start with pethidine if you're an ampule of pethidine?
Yes, sir.
You hold the pethidine ampule and then you read about that. It's an ampule containing 2 ml ampule.
2 ml.
How much Pethidine? Each ml.
Each ml is 50 mg, sir.
Yeah, 50 milligram.
Yes, sir.
So each this thing is 50 milligram. So you always say it's each ml containing 50 milligram. It's 100 milligram ampule. And as far as classification again,
Phenyl,
phenyl
phenylpiperidine derivative, sir.
derivative, it's a synthetic, the first synthetic opioid. It is the first synthetic opioid that was introduced. It's a phenylpiperidine derivative like fentanyl, alfentanyl, fentanyl, remifentanil. They're all phenylpiperidine group of drugs. So again, as far as on the mu receptors, what kind of a drug is that?
Agonist activity at mu receptors.
It's a complete agonist.
It's a complete agonist, sir.
It's a complete agonist. Does it have any antagonistic properties?
No, sir.
It may have some antagonistic properties over kappa receptors. May have,
Okay.
but not proved. One other important thing you should always remember about. So it's a complete mu agonist.
Mu receptor agonist.
Complete mu agonist. What is the log dose response curve will be? How will be the log dose response curve whenever the drug is a complete agonist? Buprenorphine is a bell shaped.
Bell
because
shape.
it's a partial agonist.
Yes, sir.
Whereas a complete agonist like morphine, pethidine, fentanyl,
Yes.
what will be the log dose response curve? The shape of the curve?
Sigmoid shape.
No, it is a linear one.
Linear.
Linear one. Linear means you keep increasing the dose, the analgesia will keep increasing.
Oh.
The side effects also keep increasing. That is what an agonist. An agonist means log dose response curve will be linear. You know, linear, straight.
Straight curve.
You keep increasing the dose, the effect also keep increasing.
It's
The response also will keep increasing. So it's a linear log dose response curve. So what are the other important properties of pethidine when compared to other opiates? What is its potency as compared to morphine? How much it is potent because I told you morphine is the gold.
gold standard.
When compared to morphine, how much potent is pethidine?
1/10.
Yeah, correct. It's
1/10 of the
potent as morphine. So 10 times less potent as morphine, 10 times less potent. So again, any other properties of pethidine is there when compared to other opioids? Like I was telling you, buprenorphine, NMDA, receptor antagonist, local anesthetic effect, like that. Pethidine. Any other than regular mu receptor agonistic effect, any other effects of pethidine?
opiate withdrawal pethidine can be used.
No. How can you use an agonist? Opiate withdrawal you cannot use. Agonist you cannot use. You can use partial agonists like buprenorphine. Antagonists or partial agonists you can use, not a opiate agonist. Agonist can by itself can produce again, dependency. What other important? No, I told you it can be used
Tachycardia.
shivering. No, it can be used for shivering, isn't it?
Shivering.
So how does it reduces the shivering, especially the intense shivering also whenever it is there in the post-operative period? You just give 25 milligrams, 15 to 25 milligrams of pethidine IV. So immediately the patient will stop shivering. What is the mechanism of action? How does it? Because this is one very important thing that will be asked for you in the exam. How does it produce anti-shivering effect?
Acts on kappa receptors.
No, that was what thought before. Now they have changed it. May not be the effect of pethidine on kappa receptors. Actually, its effect on, it has got an agonistic action on alpha 2 receptors. Adrenergic alpha 2.
Clonidine. Okay, sir.
adrenergic alpha 2B receptors. Agonistic action of pethidine produces this anti-shivering effect. That's how, even clonidine,
Chlorine also used. Yes, sir.
clonidine also has been used because
Used.
clonidine, dexmedetomidine, all these drugs
Alpha 2 receptor agonist.
used because they also have this alpha 2B agonistic effect also. So that's how it produces anti-shivering effect. One more thing, that we used to use it as a sole anesthetic intrathecally.
Okay, sir.
I told you, especially, one of our students had done a study of pethidine, intrathecal pethidine, so preservative-free pethidine, intrathecal for perianal surgeries, especially, for fissures, fistulas. So it used to be very effective drug to produce spinal anesthesia. So what effect of pethidine used to produce this spinal anesthesia? It has got very good local anesthetic properties.
Okay.
Its structure resembles local anesthetic agent. So that's how, it has been used. That is what I think it's almost like about 15 years back. A study was done and it was published also. Pethidine, intrathecal pethidine. So as a sole anesthetic because it may not produce so much of motor blockade, but intense analgesia it produces. So because of its intense analgesia and the patients will be very comfortable in the post-op period also. And because less motor blockade, the patient can be made to ambulate early. So that was how it was being used. This particular property of pethidine as okay. So what are the other effects of pethidine when compared to the routine opioids, which differ from the routine opioids, especially its effect on the CNS?
Decreases
Pardon?
cerebral oxygen consumption. So.
No. Regularly, all opiates will have certain effects like euphoria.
Yes, sir.
They also will produce nausea, vomiting, isn't it? So
Yes, sir.
that is what, and respiratory depression. So these are and analgesia. So these are
Yes,
some
sir.
common things. Whereas pethidine, what is one of the metabolites of pethidine?
Not pethidine, sir.
When it accumulates, what is its effect on the CNS?
seizures.
Yeah, it can by itself can produce CNS excitability and can that's one thing. And second thing is, suppose if a patient is on a monoamino oxidase inhibitors,
Yes, sir. Serotonin.
Antidepressant drugs are there, inhibitors, and even tricyclic antidepressants, imipramine and amitriptyline and all. So if these patients are on MAO inhibitors or on these kind of drugs, if you use pethidine, what is the drug interaction as far as CNS is?
Serotonin syndromes.
Yeah, very good. So it can induce serotonin. So what happens when the patients are on MAO inhibitors and they use pethidine? What is
They'll
the
be
syndrome?
they
What?
reduce the reuptake of serotonin, sir.
Pethidine also produces, reuptake. It blocks the reuptake
Give the reuptake of
serotonin.
that one.
And MAO inhibitors also, block the metabolism of serotonin.
Serotonin.
So together they suddenly increase serotonin levels in the brain. Quite high levels of serotonin can occur, and that produces serotonin
Tachycardia syndrome.
and an acute drug interaction. So this you have to remember when you talk about pethidine. So what is the serotonin syndrome? What happens to the patient? How does he respond?
Patient will be having Patient will be anxious and will be having tachycardia, increased hypertension, sir.
Excitement, as you
Excitement.
tachycardia, okay, hypertension, then
Hmm.
hyperpyrexia
Hyperpyrexia, sweating, okay, sir.
and convulsions. And
Convulsions.
so these are typical of serotonin syndrome. So that is the reason when you want to use pethidine, better to take a proper history. If the patient is on any of these drugs like monoamine oxidase inhibitors or tricyclic antidepressants,
Yes.
so you should be very careful in using pethidine because it can produce. So that is one of the things on CNS, which is the other opioids may not have this serotonin syndrome. They may not have this drug interaction. So this is especially exclusive to pethidine. Some very important characteristics of that particular drug you have to highlight in the exam. So when you're talking about. So the other important thing also I had discussed about pethidine as far as its effects on the CVS.
Tachycardia.
Tachycardia and
Tachycardia.
Why tachycardia?
Increase in catecholamine, sir.
No. Already discussed in my previous classes. It has got an anticholinergic side
And
effect.
anticholinergic.
You forget so fast. Anesthesia is like that. It is like keeping ether in an open bottle. After say 5 minutes, there will be nothing inside the bottle. It is like keeping your brain open or the skull open. Everything start evaporating. So you have to keep it closed, isn't it?
Yes.
Fill it, close it.
Yes.
So then it will remain inside, isn't it? So for filling, it requires a lot of refillings. So revisions, lot of revisions. So that is what, if you have not revised, you will forget things. So evaporates faster than your inhalation anesthetic agents or anesthesia knowledge. So very important, revision is very important. So anyway, back to pethidine. So very important thing is it has got an anticholinergic effect. So it increases, all opiates will decrease the heart rate. Fentanyl, midazolam, fentanyl, vicuronium can even produce asystole, cardiac arrest, because severe bradycardia can be induced by all these drugs. All opiates will produce bradycardia, except probably some of the drugs like pethidine. Pethidine has got an anticholinergic effect. It produces tachycardia.
Yes, sir.
Another thing is its effect on the blood pressure. All opiates will slightly decrease the blood pressure by their peripheral vasodilatation, whereas pethidine increases systemic vascular resistance, it increases the blood pressure. So it increases systemic vascular resistance, it produces tachycardia. Because of these effects, in which kind of patients it is carefully used or may contraindicated maybe.
Pre-eclamptic patients.
Pardon?
Pre-eclampsia patients.
No, preeclampsia. I'll come to that.
Okay.
Pethidine is one of the drugs of choice which was used before. So not
MI patients,
artery
cardiac patients,
disease.
cardiac patients.
Coronary artery disease, wherein you do not want increase in heart rate, because increase in heart rate can increase the demand and decrease the supply of oxygen to the myocardium. Any increase in heart rate, it is going to increase the demand and decrease the supply. Because why it decreases supply? Because the diastolic period is very important. Only during diastole, the left ventricular myocardium gets supply of oxygen. And whenever there is tachycardia, the diastolic period decreases.
Decrease.
Once the diastolic period decreases due to tachycardia, so the amount of supply of oxygen to the myocardium will decrease because there is no time. So that is why tachycardia will decrease the supply of oxygen to the myocardium. Tachycardia also increases the demand because, once tachycardia is there, myocardial contractility also increases. So both will increase the oxygen demand. So that is why in a coronary artery disease patient, you want to use pethidine as a pre-medicant. It is not an ideal drug to be used as a pre-medicant. And other things like in stenotic valvular lesions. Again, stenotic valvular lesions, it is a diastolic period which is very, very important, especially MS, wherein only during diastole, the left ventricle will fill from the left atrium. And diastolic period is very important, isn't it? So if you reduce the diastolic period, So left ventricular filling will not occur, the left atrial pressure will increase, the backward pressure, the pulmonary edema can also occur. So that is why it's very important that you should be careful in using pethidine because of its anticholinergic effects in patients with valvular heart disease, stenotic valvular heart disease patients, and also in coronary artery disease patients. Okay, so that is another very important thing. So you raised one thing like preeclampsia.
Yes.
So before magnesium, pethidine was one of the drugs of choice that was used in preeclamptic patients. It was called as a Lytic cocktail. You see older abstract textbooks, and especially we used to read a textbook written by Modelier. I don't know whether it is still there or not.
Is that, sir?
Long back we used to read as an undergraduate student.
Modelayer and Datta, sir. Go for
Okay.
obstetrics for Modelayer.
Okay. So in that, it is very well written, and we were also using it in our labor room when I was an intern. I still remember to have used pethidine cocktail. It is called as Lytic cocktail. So the combination of this is pethidine, 1 ml of, half ml of pethidine, then 1/4 ml of chlorpromazine, and 1/4 ml of promethazine, that is phenergan. So total 1 ml, half ml pethidine, that is 25 milligrams of pethidine, and 6.25 milligrams of chlorpromazine, and 6.25 milligrams of promethazine hydrochloride, that is phenergan. So we used to combine it with that and used to give based on the pethidine dose. Pethidine dose is 1 milligram per kg body weight. So we used to give every 8th hourly for these patients with preeclampsia. So it was quite effective to prevent because a combination of these three. Though of course, if you just think about only pethidine, norpethidine, CNS, it produces actually seizures. But when you have a combination with chlorpromazine and promethazine, so it used to be very effective for preeclamptic mothers. Of course, now after the introduction of magnesium, we don't use this Lytic cocktail at all. We routinely use magnesium sulfate for preeclampsia with severe features in order to prevent eclampsia. NMDA receptor antagonist, isn't it? So this Lytic cocktail also can be used orally as a pre-medicant in pediatric age group. As a pre-medicant. Combination of pethidine, say 25 milligrams, 6.25 of chlorpromazine and 6.25 of promethazine. Because chlorpromazine and phenergan will produce quite a bit of sedation, and they have an antiemetic effect also, both chlorpromazine and phenergan. And pethidine produces fantastic analgesia because it's a mu complete agonist. So that's how it was one of the pre-medicant, oral pre-medicant combinations. And use at the dose of 1 milligram per kg body weight of pethidine orally also. So for a pre-medication in pediatric age group.
Yeah.
Before we were also using as a pre-medicant for. So in preeclampsia, it was used as a Lytic cocktail in olden days. So that you can always tell about. And pethidine is extensively used as a through intramuscular route for labor analgesia. Already I told you about this last time. For labor analgesia, it is used by obstetricians because anything can be given intramuscularly, they are very fond of, because they know that even any complication occur, it will not occur immediately, it will take time. So body will respond also. So intramuscular pethidine at the dose of 1 milligram per kg body weight, intramuscular for labor analgesia. In the early stage of the first stage of labor, you can start with, because the first stage of labor has got two phases, the early latent phase and later active phase. So you can use pethidine in the latent phase itself. Intramuscular pethidine or even intravenous pethidine also can be used. The only thing is, you should always remember about pethidine can produce its maximum effect in the fetus between 2 to 4 hours after its administration. Maximum effect in the fetus, and the fetus can, once it is born, the neonate can have prolonged respiratory depression. So that one thing you should always remember. So suppose if the delivery is going to occur within 2 hours, you can safely give pethidine. That's what last time also I told you about the use of opiates in labor analgesia. So if you think that it is going to take more than 4 hours, like I told you in the latent phase of the first stage of labor, because first stage of labor in primary it can be about 12 to 16 hours, in multi it can be about 8 hours. So if you use in the first stage of labor, it is very safe, very safe. And what also has been found to be an advantage about pethidine and labor analgesia is that it has been found to shorten the first stage of labor. Studies have found that it is going to shorten the first stage of labor. So that's how, pethidine can also be used for labor analgesia, 1 milligram per kg body weight, IV or IM. And it's better to use within, if they think that delivery occurs within 2 hours or delivery occurs after 4 hours. But 2 to 4 hours gap is very important, because the norpethidine, which is a metabolite of pethidine, can have an effect of more than 24 hours in the neonate. It has got a prolonged duration of action in the neonate, up to about 24 hours. It can induce respiratory depression in the neonate. So that is what you have to think about. So regarding the pharmacokinetics of pethidine, again, it gets metabolized in the
liver, sir.
all opioids are metabolized in the liver, except which drug is not metabolized in the liver? All opiates except fast onset, fast offset.
Remifentanil, sir.
Except, no, everything should be at your tip of your tongue. So many times you have discussed.
Plasma
Remifentanil,
tissues.
because it gets metabolized
Tissue
by
esters.
esterases,
Esterases.
either in the tissue esterases or plasma esterases. So it is the only drug which does not require liver for its metabolism. That is another advantage with remifentanil. Whereas pethidine again requires liver, and it is metabolized in the liver by N-dealkylation to norpethidine. And you know that norpethidine has got prolonged duration of action, even almost like about 12 hours of duration of action in the adult patients also. In neonates, it can extend up to 24 hours. Norpethidine can act for about 12 hours, and norpethidine can produce CNS excitation, can produce convulsions. So in which kind of patients norpethidine can produce convulsions? Which kind of patients you have to be extremely careful. How norpethidine is excreted?
Through urine, sir.
That
Renal.
means through kidneys. So
Kidneys.
any which kind of patients
CKD.
can accumulate?
CKD
Failure
patients.
patient.
Yeah,
Renal
if
failure.
patients in renal failure patients,
Patients.
you have to be careful, because norpethidine can accumulate and can produce problems. Okay, of CNS excitement if you are using pethidine. So these are some of the things which, and usually the dose I told you, pethidine can be used intramuscularly, intravenously. And intrathecally also, I told you 1 milligram per kg body weight, pethidine has been used intrathecally. Epidurally, it has been used because of its local anesthetic effect. It also synergistic effect of the local anesthetics, and individually also you can use it intrathecally. And another important thing about pethidine and pupils, already I told you, it may not produce meiosis, it may produce
Mydriasis.
mydriasis. So that is another important thing about pethidine you should always remember about. So pethidine is, and for shivering, so just about 15 milligram bolus. You can repeat another 15 milligrams if After some time, again, the patient develops any shivering. In the meantime, you have to take care of why the patient has developed shivering. Patient has developed shivering probably because of loss of temperature from his body. By it can be radiation, it can be by evaporation, all these convention, evaporation, and conduction, convection,
Conviction.
and radiation. These are the four methods by which patients can lose heat. That is the reason we always maintain higher temperature for pediatric patients, and also many times we'll be using these warming blankets many times for prolonged surgeries, bear huggers, warming blankets. Are you routinely using for prolonged surgeries, neurosurgery,
Yes, sir.
cancer surgery?
Yes, sir, we are using warmers with
Yeah.
blankets.
Because radiation is one of the most common way of losing heat. Radiation is, temperature gradient between the patient's body and the environment. Because, in majority of these patients for prolonged surgery, neurosurgeries and all, we keep a very low temperature inside the OT. We keep about 16 to 18 degrees. So if there is exposure, more exposure, so body will start losing heat by radiation. Because one thing you should realize that all patients under anesthesia, they are like poikilothermic patients. Poikilothermic means who try to equilibrate their temperature with the environmental temperature, like reptiles, snakes and all. Have you touched any time a snake?
Yes.
You have not touched any time.
No, sir.
They're very cold because they are like poikilothermic. That means they try to have the same temperature as the environmental temperature. That's what occurs because under anesthesia, the thermoregulatory center is inhibited by our anesthetics. Once the thermoregulatory center is inhibited, especially the volatile anesthetic agents, so they lose heat if you expose their body by radiation. Radiation, almost like 40 to 50% of heat loss occurs because of radiation. Then convection, evaporation, and conduction. Conduction is direct contact.
Yeah.
Direct contact. That is why, many times thermostatically heated mattresses will be using, especially for pediatric patients. Thermostatically heated mattresses, because direct, when the body touches the particular part of the table, so directly the heat loss may occur. That is why you will never make them lie down on the metal surface of the table. You have always the mattress, and especially where you think that they are highly prone for intraoperative heat loss and hypothermia, prolonged surgeries, even thermostatically controlled mattresses are used. That is why conduction heat loss, you are going to see that they don't develop postoperative shivering. The other thing is use IV fluids, warm IV fluid, and do not, even for antiseptic solutions, use warm antiseptic solutions. So the convection currents also you could reduce. That is the air passing over the exposed surface of the body and exposed, abdomen, that can also pick up heat. So that is what, convection currents. So these are the methods by which heat loss can occur. You have to see that the postoperatively the patient doesn't develop hypothermia, because there are a lot of problems with hypothermia. But in spite of taking all these measures, still some amount of temperature decrease has occurred. Then patient once he is awake, they start shivering, because there is a threshold for shivering in the thermoregulatory center. Once the temperature reaches that threshold, a lower temperature, maybe about 0.5 to 1 degree, 37 degrees is the normal temperature. Thermoregulatory center is set at that. So once it reduces to say 36 degrees, so the thermoregulatory center get activated, and shivering is the best method of thermogenesis. Patient will start shivering. That is, the muscle contractions will occur. So when you give pethidine, one of the ways how it reduces the shivering by acting on the alpha 2 B receptor, it reduces the shivering threshold at the thermoregulator center. For example, if the thermoregulator center is set for 1 degree reduction, it's going to induce shivering. It may reduce it to further to 1.5 degrees lower down. So once it is reduced, the thermoregulatory center thinks that okay, if everything is fine, so it immediately stops shivering. So that is how shivering is immediately stopped by clonidine or even pethidine. So these things you should always remember. But in the meantime, you take measures to see that the temperature loss is not going to occur, and you are going to gradually warm the patient's body. So that's how just 15 milligrams of pethidine may be sufficient enough. Okay. Any questions on pethidine? No questions on pethidine? Everything is understood? Okay, very good. Nice. So we'll go for tramadol and tapentadol, the other two drugs. Are you using tramadol?
For shivering,
Shivering we are using
shivering
the-
using tramadol instead of
Shivering,
pethidine.
not only shivering, for in the post-operative analgesia.
Yes, sir.
Yes.
It is extensively used for post-op analgesia by the surgeons.
Yes.
And many of you who had done on studies on for post-op analgesia for any drug, as a rescue analgesic, either paracetamol or tramadol is routinely used. And one of the most commonly used analgesic. So suppose if tramadol, how it is available?
Ampules, sir.
Ampules.
Ampules. So
1 ml and 2
ml.
ml.
1
yeah,
ml.
1 ml and 2 ml ampules. So what is the strength?
50 mg per ml.
mg per
Yeah,
mg.
50 milligram per ml, like pethidine.
Pethidine.
Like pethidine, it also is available as 50 milligrams per ml. So how do you classify tramadol?
It's a synthetic,
Synthetic phenylpeptide.
it is agonist synthetic
Agonist.
peptide.
Okay, so opiate drug. And is it a weak drug or a potent drug? Because that is one of the classifications is also there.
Yes, sir.
Weak drugs and then moderately potent drug and highly potent drugs.
Moderately potent.
So it's a weak.
Weak. Okay.
The weak agonist at mu receptors. It's a weak agonist at mu receptors. It's a weak agonist at the mu receptor. So it is also classified in that also, tramadol. And how does it produce analgesia? One way is its effect on the mu receptors. Though it's a weak agonist, it produces analgesia by its agonistic action of the mu receptors. What are the other methods by which it produces analgesia?
Inhibit the reuptake of norepinephrine and
Serotonin.
So it also has got this inhibition of serotonin and norepinephrine reuptake. Especially, and that's how it is very effective in the descending pathway.
Descending pathway.
Yeah, from the brain, medulla and pons and cortex to the spinal cord. So these descending inhibitory pathways. So their principal neurotransmitters are norepinephrine and since it produces inhibition of the reuptake of serotonin and norepinephrine, so it will be very effective to produce analgesia in another method of analgesia, not only just mu agonistic. So it also has got a different analgesic effect. That's how, when tramadol has been reversed with naloxone, still its analgesia persists. It's analgesia through inhibition of serotonin reuptake and norepinephrine uptake. It principally prevents the reuptake of serotonin, less of norepinephrine. Okay, so that is one thing. So since it prevents the reuptake of serotonin, so in which kind of patients you have to be careful in using tramadol?
Ammonium oxidase inhibitor.
Yes, same thing like pethidine.
Something pethidine, yes, sir.
So you have to be extremely cautious in using tramadol in patients who are on
MOE.
inhibitors like phenelzine,
Tricyclic.
and also in patients on
Tricyclic.
antidepressant agents. So because again, they can develop serotonin syndrome. Serotonin syndrome. So that is another important thing you should always remember about. And what is the other advantage of tramadol? Can it be used orally?
Yes, sir.
Yeah, it can be used orally, it can be used intramuscularly, it can be used intravenously. So that is the advantage of tramadol. And what is its potency when compared to morphine?
110.
1/10 is your pethidine. What about tramadol?
1/5.
1/5. Okay, sir.
1/5 as potent as pethidine. So actually, how does it is tramadol itself acts, or is it a prodrug?
The product, sir.
Prodrug means what actually, which part of tramadol is actually produces all these effects of mu-agonistic action or prevention of reuptake of norepinephrine and serotonin.
New receptor will be acting, sir.
No, prodrug means what?
Before
It has to get converted
let's
to
get
another drug.
converted into another drug, yes, sir.
Like codeine is there.
Codeine.
Codeine gets converted to morphine. 10%
Morphine.
of codeine gets converted to morphine, and it is morphine which will be effective, even though it's codeine. So
Yes,
like
sir.
that, when you give tramadol, so it gets converted to which particular metabolite, which is actually the active agent.
Converted into O-desmethyl
Yeah,
tramadol.
so
O-desmethyl
O-desmethyl tramadol. It gets converted in the liver by first phase metabolism.
First phase.
O-desmethyl
Tramadol.
and it is the O-desmethyl tramadol is the active agent of tramadol. Okay. So another very important thing you should always remember about tramadol and its effect on the CNS. Unlike other opiates, what is the important effect of CNS which you have to be careful about when you use tramadol?
Seizure activity.
It can produce CNS excitation. So it can induce convulsions, very rarely, of course. So that is another very important thing we should always remember about this. And can I use tramadol along with local anesthetics for regional anesthesia and also in the epidural route?
We can use, sir.
It has been used, especially it potentiates the effect of local anesthetics. Tramadol potentiates the effects of local anesthetic. That's how it can be used, especially caudal epidurals. It has been used in caudal epidural, like 0.5 to 1 milligram per kg body weight. Caudal epidural, lumbar epidurals. I used to use tramadol for labor analgesia through the epidural route, combining tramadol along with local anesthetics because I did not have fentanyl. When I started my labor analgesia long back, almost say, I can say 25 years back, maybe more than 25 years back, I used to do extensive labor analgesia outside. Not in my, I used to practice in my hospital also, but outside I was very popular for providing labor analgesia in Bellary. So every day, at least 2 cases of labor analgesia I used to have in the evenings. So I used to use, because fentanyl was not available. So I had to use other opiates. Only opiate that was freely available was tramadol. So I used to use tramadol. So single dose tramadol, 1 milligram per kg body weight. So 25 to 50 milligrams along with 0.1% of bupivacaine. I used to use intermittent boluses. So tramadol can be used as as an along with local anesthetics. So through the epidural route, or even for other infiltrative anesthesia purposes also, like brachial plexus block or any other this thing, you can use tramadol. That is an advantage with tramadol. So what are the other features of tramadol which are actually differs from regular opioid agonistic drugs? Does it produce opioid dependency?
No, sir, does not produce opioid dependency.
Does not produce opioid dependency. What about respiratory depression?
Less respiratory depression.
Yeah, it won't produce respiratory depression because it produces CNS excitation rather than depression, isn't it? So it may not produce respiratory depression. So no opiate dependency, no respiratory depression. And what about its effect on the GI tract? Does it produce constipation? Not sure.
Does not produce
No.
constipation.
Does not produce constipation. That is another advantage of tramadol. What about drug abuse? Does it produce dependency? Are there any tramadol addicts are there?
No, sir.
It won't produce.
Yes.
It won't produce. So that is another advantage. So it won't, it's a lot of advantage, like no respiratory depression.
No respiratory depression.
And,
No dependency.
No constipation.
No constipation. No dependency.
No dependency. So no drug abuse, no respiratory depression, which is most important thing, isn't it? So that way, tramadol has got many advantages, but the main problem is it's a weak agonist at mu receptors. So it's a weak analgesic as such. So it can be used in the post-operative period for pain relief, along with other multimodal analgesia. Cannot be used as a sole analgesic in the post-operative period. It can be used as a part of multimodal analgesia, like you are also using paracetamol, you are
Paracetamol.
non-steroidal anti-inflammatory drugs, you're using tramadol, you're also using like a local infiltration block, you're also using. So like these are all, and you can also use TENS, transcutaneous electrical. These are all, the different multimodal analgesias. Nowadays, the multimodal analgesia is the most important part of preventive analgesia. What we now go for is, it's not preemptive analgesia, we go for preventive analgesia. What is the difference between preemptive analgesia and preventive analgesia? Any idea about preemptive analgesia and preventive analgesia? What is preventive analgesia and preemptive analgesia? No, these are short notes. Multimodal analgesia is the short notes for you.
So,
Now, preemptive analgesia was very popular a few years back. What they have said was preemptive analgesia means if you give an analgesic drug, like even a local anesthetic infiltration before an incision is placed, you are blocking the nociceptors there, so that the conduction of this sensation at the pain sensation is not conducted to the spinal cord. So there is no sensitization, secondary sensitization of the spinal cord. So chronic post-surgical pain can be prevented. That is what the concept of preemptive analgesia, preemptive analgesia. But, unfortunately, preemptive analgesia, though initially it was very popular, it was not successful. Though, surgeons started infiltrating locally first and then used to put an incision and used to give opioid analgesics like fentanyl before incision. So, but still there were a lot of incidences of post-surgical, chronic post-surgical pain because of the sensitization of the central sensitization of the receptors in the substantia gelatinosa of the spinal cord. So that's how the preemptive analgesia is gone now. It's what is called as preventive analgesia. Preventive analgesia starts before the incision is placed, and it is continued intraoperatively. It is continued in the postoperative period also. You are preventing pain throughout preoperative, intraoperative, in the postoperative period. That way, you can definitely prevent sensitization of the neurons in the substantia gelatinous. That's how you can prevent, chronic post-surgical pain, CPSP, which is very dangerous, which can produce chronic pain syndromes. So that's how, preventive analgesia is very important. So that way it can be used. Multimodal analgesia is the one which you always use for preventive analgesia. Multiple modes, different modes of blocking the pain at different levels. Maybe from at the level of where incision is placed till the brain. Throughout, you are using multiple drugs with different methods of action of preventing pain to produce analgesia. That is what is called as multimodal analgesia, which is very, very popular now and which is very prevalent and which you should know about and which is commonly asked as a short notes for you. And tramadol can be a part of multimodal analgesia in the postoperative period. So it cannot be used as a sole anesthetic because it is a weak opioid. So these things you should always know about. And it can be used as an intravenous infusion also. It can be used as a bolus drug. It can be used intramuscularly also. So these are different methods of administration. It can be used, I told you, epidurally and also along with local anesthetics for, infiltrative anesthesia also. But one side effect of, tramadol is the postoperative nausea and vomiting. So it is quite a bit of, it can induce PONV. So you have to take care of PONV as far as tramadol when you are using tramadol. Okay. Now coming to the other uses of tramadol, as you said, that it can also be used for prevention of, treatment of shivering also. It has been used. Tramadol has been used. Okay. So another drug I told you is tapentadol. So though we are not using tapentadol much in India, but it is being used by pain specialists. Tapentadol, oral tapentadol is commonly used. Just know about tapentadol. Tapentadol has got equipotency between morphine and tramadol. It is analgesic effect is slightly higher than tramadol, much less when compared to morphine, of course. And it is also a mu agonist, very weak mu agonist like tramadol. And the other effect of tapentadol is it also blocks the reuptake of norepinephrine. It may not block the reuptake of serotonin, but it blocks the reuptake of norepinephrine, the other mode of analgesia by tapentadol. And one more difference is tapentadol is longer acting than tramadol. Longer acting than tramadol, so that can be used orally, tapentadol, for ambulatory patients, oral there. One more advantage of tapentadol over tramadol is tramadol may not be very effective for neuropathic pain, whereas tapentadol is also effective for neuropathic pain. Neuropathic pain is pain as a result of damage to the neural tissue. So that is what is like herpes zoster, post-herpetic neuralgia, trigeminal neuralgia. All these are phantom limb pain. All these are neuropathic pain. So tapentadol is also effective for these kind of pain as a result of neuropathy. So now coming to the agonist antagonists. So we'll discuss briefly about the agonist antagonists. So I told you agonist antagonists. So usually you have kappa agonist and mu
Antagonist.
agonist and mu antagonist. So we have pentazocine. You are
Pentazocine.
pentazocine in your hospital.
Very
Fortwin.
rarely, sir.
Fortwin is extensively used by surgeons in the post-operative period for analgesia. Fortwin, that is pentazocine. That is the trade name I was telling you, Fortwin. So pentazocine is one of the common drugs. Of course, now nalbuphine is also available. Butorphanol is available since a long time, butorphanol. So these three drugs are agonists at kappa, weak agonists at kappa receptor and delta receptors. They are antagonists at mu receptors. Antagonists at mu receptors. So pentazocine can be kept for you. Pentazocine ampule or even butrum, that is butorphanol ampule, may be kept for you. Even nalbuphine. So pentazocine again, it is usually 30 milligram per ml ampule will be available. 1 ml ampule, 30 milligrams, pentazocine. And butorphanol is usually 1 milligram per ml, 2 ml ampules are available. Butorphanol. And nalbuphine, I think it is available as 50 milligram per ml. I'm not very sure, so you have to check this thing. So these three drugs are available. So what about these drugs? Agonists, antagonists. Do they produce very effective analgesia or they may not produce very effective analgesia?
Effective analgesia.
Compared to mu agonists like morphine, pethidine, fentanyl.
Effective, sir.
Whenever drug has to produce analgesia through its effect on the kappa and delta receptors, the analgesia is not complete. It is not very effective. Analgesia will be there, but it is not as good as the combination with the mu agonists. Like you have morphine, fentanyl, all those things. So the effect is much less, the analgesic effect. So like pentazocine may be 1/5 as effective as morphine. Just about 1/5 as effective, including nalbuphine and butorphanol also. Not very effective. And the other important thing is, suppose a patient is on fentanyl you are giving. Can you also add pentazocine?
No, sir.
Yes, very good. Why no?
Withdrawal symptoms will be there, sir.
No, not withdrawal as such immediately. No, it can actually the amount of analgesia may suddenly come down.
Okay, sir.
Withdrawal will occur when the patient is on opioid abuse.
Opioid abuse.
Now I told you post-operatively you are giving fentanyl. You had given fentanyl and still patient complain of pain. I cannot go and then ask you to give pentazocine because pentazocine produces mu antagonism, isn't it? So, but alone you can use as a part of multimodal analgesia. You can use pentazocine by its effect on delta and kappa receptors. It also produces analgesia. Another important thing about these three drugs is that they have a ceiling effect because they are partial agonists at mu and kappa, the weak agonists. So they have a ceiling effect and ceiling effect for analgesia and respiratory depression, both. So that is another very important thing you should always remember about. And the third important thing is, regarding its effect on the CNS. Because, all regular mu agonists will produce euphoria, whereas kappa and delta agonists like pentazocine, nalbuphine and all, they produce what?
Dysphoria.
Produce dysphoria. The another disadvantage is they produce dysphoria. And because they have a mu antagonistic action, they can be used for antagonizing the respiratory depression of mu agonists. Can be used, but since you have got naloxone, we don't use pentazocine for antagonism of respiratory depression of mu agonists. So the advantage of pentazocine for antagonism of respiratory depression by mu agonists compared to naloxone. So the problem with naloxone is when you give not only respiratory depression, the analgesia also will just go off. When you want to use naloxone for respiratory depression produced by mu agonists, the analgesia, so the patient will have intense pain. But when you use pentazocine, so pentazocine by itself produces analgesia. So this problem may not be there with pentazocine. So that is an advantage with pentazocine, but it is not routinely used for respiratory depression. But because by itself it also can produce respiratory depression by acting on the kappa and delta receptors. That is why it is not routinely used for treating respiratory depression of morphine or other opioids. Okay, so pentazocine can be used for pruritus induced by opioid, other opioid drugs, mu agonists. Especially just about 15 milligrams of pentazocine will treat the pruritus, which was induced by the mu agonist. So this one thing which you can remember about pentazocine. The other important cardiovascular effects of pentazocine. What are the cardiovascular effects of pentazocine?
Causes
Cardiovascular effects.
Increase heart rate.
Increases heart rate, increases systemic vascular resistance, increases pulmonary vascular resistance, also produces myocardial depression. So because of these things, you have to be extremely careful in using pentazocine in patients with cardiac diseases. But which particular drug among them, like you have nalbuphine, butorphanol and pentazocine, which drug does not have these cardiovascular side effects of heart rate increase, blood pressure increase, pulmonary vascular resistance increase?
Butorphanol also.
Nalbuphine. Nalbuphine does not produce this. And which of these drugs may not produce dysphoria but may produce intense sedation? Butorphanol.
Butorphanol.
Butorphanol may not produce dysphoria. Unlike pentazocine and nalbuphine, it produces quite a bit of sedation. And butorphanol, we had actually did a study of butorphanol when it was recently introduced as Butram by Neon. That was almost 30 years back. So we used butorphanol 2 milligrams epidurally along with bupivacaine, intermittent bolus. And when it was almost like giving an IV butorphanol, immediately the patient used to start snoring within few minutes of epidural butorphanol also. So butorphanol produces quite a bit of sedation. Even IV butorphanol, 2 milligram butorphanol, 1 to 2 milligram is also used as a pre-medicant drug. Among all these, agonists, antagonists. So these things about the agonists and antagonists. Now coming to the antagonist. Any questions on pentazocine, butorphanol and nalbuphine? Anything to add? Because you might have read more.
The tramadol, why it causes nausea, vomiting? Because it acts on chemosuppressive sir.
Yeah, same thing. Like
Same
any
thing.
other opioid. Though it may not produce respiratory depression, but nausea and vomiting is one of the common side effects. Even these pentazocine and nalbuphine, they also can produce nausea vomiting by their effect on the area postrema, that is chemoreceptor trigger zone in floor of the fourth ventricle.
Yes, sir. And they are telling that if we give emission, the analgesic potency of the tramadol is reduced as well.
No, it will not.
No.
It's nothing to do with the analgesia,
Okay, sir.
Definitely you can use.
Okay, sir.
Can definitely use.
Mm.
Yeah. So one thing regarding you asked about this emisset, I just remembered about buprenorphine, because
Okay, sir.
buprenorphine can produce prolongation of the QTC interval.
Okay, sir.
That is, drug interaction between emisset.
Buprenorphine.
What is emisset? Emisset is a trade name.
Ondansetron, sir.
Ondansetron.
Sir.
So ondansetron also produces prolongation of the QTC.
Prolongation of QT.
Buprenorphine also produces prolongation of the QTC interval. So in patients with known to have a prolonged QT interval, what complication these drugs can produce intraoperatively?
Arrhythmia.
What kind of arrhythmia?
Bradyarrhythmias.
Torsades de pointes.
Okay, sir.
The multifocal ventricular
Okay, sir.
multifocal ventricular tachycardia, torsades de pointes is one of the complications, and that can occur because buprenorphine produces prolongation of the QTC interval. So even our inhalation anesthetic agents also produce prolongation, like desflurane, sevoflurane, and isoflurane. Plus, antiemetics like ondansetron. The other antiemetics, like we have granisetron, paleocetron. They don't have ramosetron. They don't have this prolongation of the QTC interval. It is only ondansetron has got this property. And another notorious drug which can have prolongation of the QTC interval and can induce torsades de pointes is droperidol and haloperidol. Droperidol was extensively used as an antiemetic before. And now we don't use droperidol for its anti-emesis effect because of the, it can produce the, torsades de pointes, because it produces quite a bit of prolongation of the QTC interval, and especially in those patients already having a protein patient, droperidol. Because droperidol and fentanyl combination used to be used before extensively. Combination of droperidol and fentanyl. So it used to come in in a single ampule, combination of fentanyl and droperidol. So nowadays, because of this problem with prolongation of the QTC interval, that was called as neurolept analgesia. So remember about neurolept analgesia, it's a combination of fentanyl and droperidol. So at the ratio of 1:25, 1 part of fentanyl and 25 parts of droperidol. And it used to be used for extensively for outpatient procedures before. So it just gave, patient would be drowsy, and because of droperidol and very good analgesia. So for short procedures, neurolept analgesia was extensively used. Sometimes they may ask you, some older anesthesiologists, if they come as examiners, and fentanyl is there, where else fentanyl was being used? So neurolept analgesia along with droperidol, 1:20 ratio combinations. So that and droperidol now we don't use because of its effect on QTC interval, prolongation. So buprenorphine also can produce prolongation of the QTC interval. So you have to be careful. Okay. So coming to the other antagonist is definitive antagonist for all kinds of opioids except probably buprenorphine is naloxone. So naloxone also, have you seen naloxone ampule? No, you should always keep it there ready in your labor suit and also in labor OT. Sorry, in cesarean OT. Because I told you, especially where Patients with preeclampsia, if they have HELP syndrome, then you have to go for GA. In patients with HELP syndrome, you cannot go for spinal or epidural, isn't it? So when you want to go for GA, and you have to suppress the intubation response in these women. Otherwise, GA for cesarean section, you don't use opiates before. You use opiates after the extraction of the baby. But here you may have to give even 2 micrograms per kg body weight you may have to use. And you have to tell the pediatrician to keep ready with naloxone, isn't it? So naloxone can be kept for you in the exam, can be asked as a short notes also. So naloxone is usually, what is the, each ampule of naloxone contains how much? Each ampule contains 400 micrograms. 1 ml ampule, 400 micrograms. What is the dose of naloxone in neonate when it is born? And suppose if you have given high dose opioid before, and the neonate is born with respiratory depression, now you have to give naloxone. How?
0.5 to 1 mix.
No, it is available as 400 micrograms in 1 ml ampule. You have to dilute it and then use it. It is in neonates, it is 100 micrograms per kg body weight. 100 micrograms per kg body weight is the dose in neonate. So if the neonate is about 2 kg or 3 kg, you may have to give 200 to 300. So 1 ml you dilute and then you can definitely use it. What about the adult dose of naloxone? In pediatric, neonate, it is 100 micrograms. Suppose a patient has developed respiratory depression and you want to reverse it with naloxone, opioid-induced respiratory depression.
1 to 2 mics per kg.
That means just about 60 mics, is it? 60 or 70 mics. So when it is 100 micrograms per kg body weight in pediatric, what is the dose in adults? It is 10 micrograms per kg body weight. Roughly 10 micrograms per kg body weight. But you don't give the total dose straight. You are going to give in increments, waiting for 5 to 10 minutes or even at least 5 minutes before each increment. You go for increments of 40 micrograms. You dilute it in maybe about 10 ml or 20 ml syringe and start injecting 1 ml or 2 ml each for naloxone. So why should you titrate naloxone? What is the problem in adults when you give straight, say 600 micrograms? Like I told you, 10 micrograms per kg body weight. So you require at least about 400 to 800 micrograms of naloxone may be required. Say 1 ampule or 2 ampules you require to give. But you don't give straight the whole thing. So you dilute it and then in increments of 40 to 60 micrograms increments you will be giving. Why? What happens if you give the total dose straight?
Analgesic effect will be.
No, when you want to give naloxone, you should also provide alternate method of analgesia. You cannot just give naloxone to reverse respiratory depression, opioid induced, because analgesia also will be reversed. So definitely you have to take care of analgesia and then you should give. So one problem with naloxone is it can produce
Tachycardia.
pulmonary
Catecholaminerally release due to catecholaminerally.
hypertension, and some patients even pulmonary edema. Sudden higher sympathetic activity it can produce. Sudden high sympathetic, maybe because of pain also. Maybe because of suddenly because you have reversed the analgesia effect also. So suddenly because of pain also, hypertension, pulmonary edema also may occur. So that is one thing you should always remember about. And what is the duration of action of naloxone? How long it will be effective?
Half an hour,
13 minutes.
30, half an hour to
16
40
minutes.
minutes.
Is 2 to 3 hours. Maximum duration of action of naloxone is 2 to 3 hours. Now, why should you know that duration of action of naloxone is just 2 to 3 hours?
Because
Why should you know? Okay, you had given
First.
morphine has produced respiratory depression. You have reversed the morphine respiratory depression by naloxone.
okay, sir.
Okay, so because you know that the duration of action of naloxone is 2 to 3 hours, but what about the duration of action of morphine?
6 to 8 hours.
No, it can be even more than that, isn't it? It can be up to 24 hours.
24 hours.
So what is the problem now?
It, it can be used only.
No, there can be a recurrence of respiratory depression.
I said.
Once the effect of naloxone goes off, again the patient will will develop respiratory depression. You may have to give repeat doses of
Repeated doses.
No, just
but that means you have to monitor the patient. You have to monitor the patient. Not that, okay, you have given naloxone, okay, fine, everything is fine. The respiratory depression is reversed and afterwards there may not be any respiratory depression. No, it cannot be because morphine duration of effect is only 2 to 3 hours. So, but what has been found is, because there is always a threshold for respiratory depression, the threshold concentration of the opioid on the mu receptors, which can produce this respiratory depression. So once you give naloxone, so much of the drug may be removed from the mu receptors. So that's how there may not be again recurrence of respiratory depression, because even though the effect of morphine will be there on the mu receptors, analgesia will come back, but the respiratory depression may not occur because that high concentration of morphine may not be there at the mu receptors. So that way, but anyway, you have to monitor the patient. There can be recurrence of respiratory depression, which is another drug which is absolutely an antagonist, which has got more longer duration of action than naloxone. Naltrexone.
Naltrexone.
Has got longer duration of action, 6 to 8 hours. So instead of naloxone, one can use naltrexone. Okay, so this important thing you'll have to remember about. So, but whenever you want to, reverse the respiratory depression, see that patient is given other mode of analgesia, because naloxone is going to reverse both respiratory depression as well as analgesia. But if you have given intrathecal morphine and respiratory depression has occurred after about 6 to 8 hours, when you give naloxone, only the respiratory depression part of morphine will be reversed, because naloxone cannot act on the mu receptors on the spinal cord, because the analgesia by when you give morphine is basically by its effect on the mu receptors on the spinal cord. Okay, so that way no problem. Whenever you give intrathecal morphine and patient has developed respiratory depression, you can reverse respiratory depression by naloxone. The analgesia will not be reversed when you are given intrathecal or epidural morphine. So that is an advantage with intrathecal and epidural morphine. Okay, so this will conclude our opioids. I think how many hours we just discussed opioids. Extensively we have discussed about opioids because very important topic for your exams also, and for your, you have to be a safe anesthesiologist, isn't it? Unless you know extensively these drugs routinely you are using, you cannot be a safe anesthesiologist. So that is why I went into quite a bit of details about opioids. So one of the commonest drugs you always use. Routinely for every patient you will be using either regional anesthesia or general anesthesia. Opiates are very commonly used, and opiates are the part of balanced anesthesia technique. When the concept of balanced anesthesia was introduced by Simpson, so it was always the combination with opiates, combination with hypnotic agents, muscle relaxants, and opiates. That is what is balanced anesthesia technique, isn't it? So, any doubts? We still have 2 minutes. I thought I'll finish it off today, half an hour, and we'll take up with the non-opioid analgesics. So, but we took another 2 hours for discussing opiates, individual opiates. Any doubts you have regarding opiates? Anybody else has got any doubts regarding anything regarding opiates? So anyway, tomorrow, if you have any doubts, you can tell these doubts to the next batch
Okay, sir.
of students who will be presenting on non-opioid analgesics. Especially, we'll discuss more about tomorrow about paracetamol and non-steroidal anti-inflammatory drugs. And of course, the other drugs for neuropathic pain, especially pregabalin, gabapentin. Also, we can have a discussion. And other drugs that are used for neuropathic pain, like tricyclic antidepressants like amitriptyline, imipramine. So these are the drugs which we'll discuss tomorrow, mainly concentrating on paracetamol because extensively it's being used as aspirin, because many of these patients now will come with low-dose aspirin therapy, which is again a non-steroidal anti-inflammatory drug, and other non-steroidal anti-inflammatory drugs. So I think tomorrow will be another group of students. Isn't it? Okay, let's meet tomorrow.
Yes, sir.
Thank you, sir.
Yes, sir.
5 o'clock.
Thank you, sir.
Okay, sir. Thank you, sir.
Thank you.
sir.
Thank
Thank
you,
you.
Aarti and
Thank you, sir.
Gaurav,
Thank you,
for
sir.
Thank
Thank
you.
you, sir.
good discussions.
Thank you, sir. Thank you, sir. Thank you, sir.
Please, Darren.
Reference.